Welcome back to the Barbell Medicine podcast, where we bring modern medicine to strength and conditioning and strength and conditioning to modern medicine. I'm your host, Dr. Jordan Feigenbaum, and on this podcast, we're going to talk about lab testing, specifically direct-to-consumer lab testing, which Dr. Baraki and I did ourselves, and now we're going to talk about it. Now, the reason we chose this topic is because the direct-to-consumer market has exploded, growing 20-fold between the years 2010 and 2020, and it's expected to be worth about $6.3 billion, that's with a B, in 2032 in the United States. Now, whether it's the convenience of not having to consult with a doctor, the self-empowerment of choosing your own labs, or the ability to get highly specialized tests that your doctor may not order or want to order, a lot of folks see nothing but upside when it comes to direct-to-consumer lab testing. However, a growing number of direct-to-consumer lab tests are now conducted in non-accredited laboratories, which are not regulated under the same performance standards as medical laboratories, which perhaps contribute to the nearly 4 times higher rate of lab errors compared to the labs that your doctor orders. Plus, many of these labs haven't been studied extensively or at all in humans, making it difficult to know what to do if you have an abnormal result. And so on this podcast, we'll discuss our own experience with direct-to-consumer lab testing and make some recommendations about what you can do to improve your health through testing. All this and more on this episode of the Barbell Medicine podcast. On the other end of the line is the second most handsome doctor in North America, Dr. Austin Baraki. What's going on, man?
Hey, here. Got a lot going on in my life at the moment between work and barbell medicine stuff and upcoming move and attending on the wards and teaching. So yeah, juggling a lot at the moment, but we're here.
How are your juggling skills? Like if I gave you 3 apples, do you think you could juggle that?
I absolutely can juggle 3 items. I don't know about 4.
I don't know that I could juggle 2 items. If I'm being honest, which is not juggle. Like I feel like the definition of juggling, like there has to be one thing in the air at all times.
Sure. Yeah.
And so like 3 is like the minimum. I don't think I could do it.
Well, it sounds like you're meeting expectations for a powerlifter then in terms of athleticism.
That's right. Yeah. I think the higher your powerlifting total, the lower your general athletic ability goes. And so, yeah, in that regard. Well, so hold on though. Like I can play golf. Do we consider like golf to be an athletic endeavor, or is this more of like a game rather than a sport?
I think there's no right answer here because either answer we give is going to trigger a lot of people.
Yeah, trigger them, whatever. That's people are going to get triggered at some point of this anyway. All right, well maybe we'll just back off that topic. But yeah, a lot of things going on in your life, a lot of things going on in my life, but people aren't here for our personal stories. Maybe we'll have a personal update at some point on the Barbell Medicine podcast. Let's just talk about some announcements first, and then we got a lot of lab stuff to talk about, so we get to nerd out. So some announcements. First off, our second generation General Strength and Conditioning 1 template. We just finished updating that. By the time this podcast goes up, it will be available on the website and on the app. We've got a 2-day in-season version. So if you are an actual athlete participating in sport regularly with practices and competitions, and you're like, well, how do I balance my resistance training and my conditioning with my sport? This is our go-to template for that. Also have 3-day and 4-day options that will be available by the time this podcast is live. Also, we have a new product offering called our program library. Now, I, tried to maybe float the idea of calling this like program hub, but that was shot down for obvious reasons. Although a funny aside, when I was applying to residency and when I realized I matched at UCLA, do you know what the name of their like central clearinghouse was, this like portal to submit all my information?
I feel like you might have told me this before, but refresh my memory.
It was MedHub. Yeah. And if you don't get that joke, maybe just fast forward. Yeah, it's not for you, but yeah. So anyway, this program library, you get full access to the entire Barbell Medicine cadre of training programs. All of the training programs we've ever published, all of our templates, you get access to for one low price. It's $12.99 per month. I've linked that in the description below. So every new program that we add, you have access to that. You can obviously see all of the templates, all of the programs, the first week of it, just like you can now for free. And then you can pick one, switch whenever you want. Go from there. Also, we have a new article on the website, how to train while losing weight. We had a podcast about that previously, so if you prefer to read, if you feel like you learn better through that and you want to see the references, those are all there on the new article. We also just released our testosterone course, which is our first educational course of many. We've got some other ones coming out as well. So Dr. Austin Baraki is your instructor. If you want to learn about the physiology, the treatment of low testosterone, the implications of having low testosterone, lifestyle interventions, pretty much everything, that is available as well, and linked that in the description below. And finally, we are offering free form checks. So if you have ever wanted to have your technique on a particular exercise checked by a Barbell Medicine coach, you can do that now for free. Just go on our website, click the shop tab, then form check. It's free at checkout, and then the instructions will be sent to your inbox from there. All right, I think that's it for announcements. Anything you want to let people know about? Any announcements?
Nothing else.
That's
I
it?
think those are the big ones. Yeah, if anybody's interested in the course, I think that took up a fair amount of my time in the fall and winter time frame. And it's not just oriented to clinicians. Just to be clear on that it's anyone who's interested and enthusiast, coaches, trainers. I think there's a lot to be gained from it from that perspective as well. Because this is it's a topic we've gotten asked about so much over the years that I finally just put my head down and put this together as like the packaged answer to almost anything we've ever gotten asked about the topic.
Yeah, if you work with people who either ask you questions about testosterone, the implications of a particular testosterone level, or if you're curious on your own, accord, this is the course for you. I have not seen anything like this. And when I was coming up in the ranks as a strength coach, or even just a general strength enthusiast before I was coaching people, this would have been very, very useful. Instead of like, hey, eat more saturated fat to boost your testosterone levels.
Yeah.
Okay. Anyway, all right, well, let's get into this. So we both got some labs done, and this was not like a general, like, oh, we got to go see our doctors, and then they're ordering them for us. We did it on our own accord. So first off, just why did we get these done? Austin, why did you get some labs done?
Yeah, it would seem a bit confusing to some folks who might have been listening to us for a while. So this is not something that I specifically actually sought out. There are a variety of these companies in existence at the moment. And given that they are, money-making operations with commercial interests, they seem to have various marketing strategies. And one of those appears to have been, let's send out contacts to people who are deemed maybe who have some kind of influence in this space, influencers, if you will, and offer them essentially like a free membership to this thing where you can actually come up and get all these lab tests done that you would normally pay a pretty significant amount of money for access to their services on an ongoing basis. So I had received a message from this particular service that we will leave unnamed for the purposes of this podcast. And initially I saw it and I was like, yeah, this is not the kind of thing that I would be usually interested in doing. And then in the aftermath of that, the next day, I just kind of pondered it. And I said, well, this is such a big thing. It's almost like a journalist doing a story and like going through it in order to be able to describe what was done, what the experience was like, implications, pros, cons, et cetera. So I said, let me just do it actually as a project for the podcast and for us putting out information on this. And so, yeah, I ended up taking them up on this generous offer of essentially free membership to this thing and being able to get boatloads of labs done, many of which I would not have normally gotten, as we will get through in this podcast. And so that's how I came to this topic. What about you?
So I had to get cleared for an operation, small surgery, and so I needed to get labs done. And so I got it's funny. The surgeon was like, "Hey, you need these labs. Do you want me to write you like a lab order for them, or do you just want to do them?" And in my brain, just wanting to get out of that office as soon as possible so I could like continue on with my life, I was like, "Oh, I can take care of this." And then I was like, "Wait, can I do this?" And then, I mean, obviously, I still have some prescribing, but I could, go through quote unquote the appropriate channels to like contact a medical laboratory. But the thing is, since I don't actually practice medicine full time, I don't have like a contract with like a laboratory service. So I was like, oh, the easiest thing for me is to actually just do this sort of direct to consumer lab testing. So a person came to my home and, vampired me, took my blood, and then I got my results. And so I did this for, the small surgical procedure I just underwent. We'll leave that for another podcast. Not super stoked on the what I'm doing right now because I can't lift very heavy. But anyway, yeah, so that was my answer. I got far fewer labs than you performed.
Despite getting far fewer labs than I did, you probably, if we're as being super strictly adherent to guidelines, even you, a completely healthy adult undergoing a low-risk non-cardiac surgery, probably didn't even need the ones that you did get, but we'll leave that for another time.
Yeah, fair enough. So, which actually brings up an interesting question, and we will iterate on this and expand on this as we go through the podcast, but like, who needs labs? Right. So even like my own father, right? And he has me as a son for better or worse. And, sometimes we'll talk. He's like, I got my yearly labs done. I'm like, yearly labs. And obviously, depending on someone's medical history and current, medical situation, there are definitely good use cases for, serial monitoring of various laboratory tests. But generally speaking, having just a set of annual labs that you just get for no other reason than just like checking a box, that doesn't really make sense. And so perhaps what do we say, $6.3 billion, question is what this market's going to be in 2030 or something like that in the United States. Who needs labs? Like who should be accessing these things? What's your opinion on that?
Yeah, I think to your point, this is something we'll iterate on throughout the podcast, but it's helpful to kind of break this down across different clinical perspectives. I think the one big picture would be just like from a big picture public health standpoint. And this is like population wide, what kind of things are, cost effective and lead to better outcomes if we screen for these things. For example, like everyone's getting a blood pressure screen. That is very inexpensive, very accessible, and has a significant potential to improve population-wide health. So from that perspective, that is a certain kind of cohort or a certain perspective on testing. The other way to think about testing differentiates between screening tests and diagnostic tests. So again, screening is this idea of looking at people with no signs or symptoms of disease, trying to identify problems before they manifest in some way. It's an attractive idea. In some situations, it helps. In some situations, it doesn't. And so that's another aspect, people with no signs or symptoms. The last is in a diagnostic way. So meaning a person has some kind of a problem or a sign or a symptom, and we're doing a test because if that person shows up with this symptom just by taking a history and physical exam, maybe we can't get to a diagnosis confidently enough. So if I have a young, pretty healthy person who says they've been around somebody who's sick and they come in and they've got a cough and they've got some, runny nose, I'm already confident enough based on their history and exam that they probably have a simple viral upper respiratory infection in most situations. And I don't need any further testing to go beyond that. But if I have somebody who comes into the hospital with a much more nebulous syndrome or something vague, then maybe my history and exam are not quite enough. And I can use diagnostic testing to make progress on what are the probable, more likely, less likely types of diagnoses to get to an ultimate answer.
Well, yeah. And one thing I would also try to put in here is like, that's obviously your pre-test probability of finding something that is not only abnormal, but also like actionable and relevant to the person's, syndrome that brought them into the hospital, much more likely than somebody who's just out there in the world and maybe like, we'll call it medically curious. Yeah. They're like, well, I'm a healthy, 30-year-old, but I haven't seen my doctor. I don't have a doctor, in fact, which is quite prevalent. In fact, I should probably get some labs done, and it's like, okay, if true, if we take that assumption for what it is and say, yeah, there's some labs that would probably benefit you, the individual, what are the odds that individual actually knows which labs to order?
Yeah.
And like, how could they ascertain that information without like clinical,
Yeah, simply put, I mean, they won't. And so among that kind of general population view, I like to break people down into two big buckets that I'm going to think of. There's going to be like what I'll call the minimizers. Those are people who are just trying to do as little as possible, and just want to go about their life as unencumbered by the healthcare system and doctors as possible, which is a significant swath of the population. And so that's where I'm going to stick to the stuff that is most accessible, most cost effective, has the biggest bang for your buck in terms of impact on your lifespan, like blood pressure, for example, right? And then at the other end of the spectrum, there's going to be people who we can label more as like maximizers. And these are people who want to do as much as possible, who are okay with a lot of contact with the healthcare system, who are okay with, some risk, for example, of false positives or complications or like the anxiety around that, Or these are the people who are most focused, for example, on like, optimizers, or like getting the most longevity possible and doing every possible thing that you can. Or, for example, performance oriented people who, want to make sure, to the extent they can, that they leave no stone unturned. And I do understand these two perspectives. And so I think if we speak to somebody who's a maximizer in this way, who's like, I'm willing to do anything and everything I can that will potentially give me benefit in health span, lifespan, performance, anything like that, if we talk to them as if we're talking to a minimizer and say, nah, you just need to like, get your BMI down or something like that, then that's not going to be very well received. And we're going to effectively like not get through to that person. And so I do understand that general perspective, especially among people who are not clinically trained, don't have experience, ordering, interpreting, applying labs and lab results, the allure of just doing more all the time. And so it is possible to do enormous amounts of tests. And that is not often the wisest decision. I think that sometimes we might be viewed as being anti-testing, which is very amusing to me, knowing what my full-time job involves when I work as an intern. Like, overwhelmingly, my day involves assessing patients and interpreting a lot of tests. And so I make quite frequent use of these things, but it's a very selective, targeted, and like rational approach to using these things. And so I do think that there is certainly value to testing. It just needs to be done intelligently. And I think that's where some of these direct-to-consumer companies that we are talking about today can fall short by using what we'll call like shotgun approaches. They just have enormous panels that they order on everybody, no matter what. And that would not be our approach to this kind of thing.
Yeah. The other big issue that we'll continue to probably refer to and discuss is that when consumers do access these types of services and they do order whatever tests, one of the bigger issues is that they're going to get some results back, and then putting those into any sort of context as far as like what do, that's difficult. So it is very rare for people to just get a lab test done and then a single result comes back, right, with like, okay, it's normal, and that's it, right? Generally speaking, these direct-to-consumer labs have like this is an optimal range and this is like out of range or whatever. And occasionally, particularly if these are enterprising companies looking to maybe maximize market share or whatever, or entice people to purchase their products and services, they'll have some sort of like discussion of like, yeah, well, your level's here and here's really where we want it. And it's like, you got a reference for that handy? And again, this is not with a clinician like live, where you're talking to that individual and being able to like put this into context for that individual. So that's tough. And I even know people, they are not medical professionals. They're in this sort of like health, wellness space, and they're like, oh, we got to get labs done. And we got to get labs to see how I need to coach you, whether it's training, whether it's nutrition, supplementation. And it's like, I have concerns about that. So we'll discuss that for sure.
Yeah. And I think that, I wouldn't want to paint with too broad of a brush around this concept of lab reference ranges and normal ranges. There are situations where the astute clinician will recognize when the reference range of the lab maybe doesn't apply to the patient in front of them, or there are other clinicians who have hot takes around what the reference range should be. And there are some tests that I'm that person.
Yeah.
For example, like with blood ferritin testing for iron deficiency, my hot take is that the lower limit of normal, especially in women, is way too low. And that lower limit of normal should be a lot higher than it is. And I have a fair amount of references and evidential support for that claim. So it's just something that needs to be taken on a case-by-case basis, not only from lab to lab, but also like the patient to patient. How does this lab apply to this patient? Does this patient look like the type of patient on whom this reference range was established in the first place? So there's a lot of considerations here.
Yeah. So as far as who needs labs, I think both of us could come up with labs that would be likely to benefit anyone, whether they're a minimizer or a maximizer or whatever. And then as far as, what specific labs, well, that's going to be dependent on the individual. And so the way I would envision this working, if I was thinking of like a great strategy to maybe offer direct-to-consumer testing, would be, okay, you pop on a website, you plug and chug your personal information in a protected way in there, and it kind of gives you a list of recommendations that are, in fact, evidence-based. Like, hey, look, based on your age, your behaviors, your medical history, your concerns, these are the things that you could potentially consider. And these would be like maybe a basic, sort of like the minimal amount, and this would be like the maximal
Sure.
amount. And you could go from there. But unfortunately, that's not really what's happening. And we would also remind folks, hey, like don't forget about blood pressure because that's important too.
Totally.
So,
That's the most important, I think. Yeah.
So just briefly before we actually dive into our actual results, you're going to get some of our actual numbers here. You're going to see how healthy we really are. What was your experience? So did you get like a home test kit, or do you have to go somewhere and they sucked you dry, or what?
Yeah, because of the sheer number of tests that were involved, I had to go to a place, and actually had to go to a place twice, like a week or two apart, just because it was a lot of vials of blood.
Oh, interesting. Did you know how much they took from you?
I didn't count it, but it was a lot.
Yeah. Relatively unpleasant. Yeah. I had a nurse who came to my my place, and I think it was only 2 little vials of blood or whatever. And she's like, "How come you're not watching?" And I'm like, "I don't particularly like needles or blood. I mean, if I had to pick, particularly if it's my own." So
that's an odd question to ask, since it's very normal to not look.
I know it'd be weird if I was like staring at it or like videoing it or something.
Yeah.
And then when you got your results, they got emailed to you, I assume?
It was through like a portal type setup. Yeah.
Yeah, same thing. Portal, and I got to click through this thing, and I guess they're going to disappear at some point. And I'm like, yeah, they're like, yeah, we only keep these up for 6 months. And I'm like, then what? Where do they go? Like just into the ether? Like it seems like
they're somewhere. They're definitely somewhere.
Yeah, fair enough. All right, so let's talk about our actual results here. Austin, we'll start with you, and we're gonna, again, you had hundreds of different lab biomarkers that
comical.
were
Comical now.
Yeah. So let's talk about some that were notable, or maybe just tests that are common. We can start with the CBC, the complete blood count. Again, if you went to see your primary care doctor and you're an adult at pretty much any age, and then they were like, "Hey, so when's the last time you saw a doctor?" And you said, "Oh, I don't know, years. It's been years." It'd be highly unlikely for you to leave that office visit without an order for some lab work, and likely one of those labs is going to be a CBC, because we just cannot not order one of those. And so you obviously had no abnormal results on your CBC. But people, again, and doctors, just have this idea like, well, CBC can be highly useful, which I agree in certain cases. But as far as general screening goes, that may not be the case.
Yeah, I think from both a general screening standpoint, and also like even in a hospital type setting where I work day to day, the CBC might be one of the most overdone tests in existence. That it is phenomenally useful when it is useful, but it is done way more often than it is actually useful, I think. So yeah, super commonly ordered. I don't think that if you have somebody who is completely healthy, says they feel great, have no complaints, they're performing well, all is well in their life, they're not somebody who necessarily must have one of these tests done. If somebody, again, who are among these maximizers and they're paying for their own labs, and they're like, I just want to know, it's almost like when people ask us about stretching or foam rolling or whatever, we're like, I don't care enough if you want to do it and you spend your own time and money on it. But from a general health standpoint, like a recommendation for nationwide CBC screening, I don't think that would have any real measurable impact on like the general health, longevity, morbidity, mortality of the population
in a positive way. Anyway, yeah. What you would find is like some spurious results, because obviously there's some sort of lab error baked into every lab test, and so you're going to get some people with some false positives, right? And that's going to trigger a rather extensive workup to figure out why they have that abnormal analyte. And then other things are going to be like actually perfectly normal, but like borderline low, for example. And people go, "Whoa, what do I do about this?
What do I do about my mean platelet volume?" And no doctor is going to have an answer for you, because there's nothing that can be done. And again, my point earlier, that was on a complete broad whole population level. There are certainly subpopulations who might be more likely to benefit from this type of testing. And there are also subpopulations in different parts of the world that are more likely to benefit from this as well. So there's a lot of this kind of targeted testing that can offer benefit in comparison with widespread population screening, say in the US, of like all, adults. Whereas if we looked at, say, women who are menstruating, then there's a different potential yield of this, or women who are pregnant, also a different yield of this, or people in other parts of the world where iron deficiency anemia is like among the most leading causes of morbidity, as compared with the US, where it's back pain and depression. So the likelihood of a test being useful does vary a lot on who you're doing it in.
Yeah, you likely collect that information again on that website that this theoretical website, and you'd be like, oh yeah, this person actually would likely benefit from a CBC, and this person it's
Yeah.
of no clinical yield. Yeah, all right.
Yeah.
So you had that test. You were normal. I also had mine done, and it was also normal. I would like to point out that I had a higher hemoglobin than you by 1/10, which sure is within the error bar of the test.
Solidly within error.
But I would like to point out that mine was higher than yours. So
there you go.
Yeah,
congratulations. 14.7 for me and 14.8 for you for people who are keeping score at home on grams per deciliter scale of hemoglobin.
Yeah, athlete. Yeah,
there you
just
go.
A lot of endurance work.
Which is interesting since as you know, as far as I'm aware, in El Paso, I live at slightly higher elevation than you. So curious.
Yeah, well, like I said, I'm an athlete, so just really expanding my my formed elements in my blood.
Or you have undertreated sleep apnea, and it's compensatory for your nocturnal hypoxemia.
More likely, but we'll leave that alone for another podcast.
All right.
All right. So moving on to your electrolytes and kidney function. So you had a complete metabolic panel because you also got some liver function tests and whatever. We'll focus on the kidney function. Again, you had normal electrolytes. No surprise there. Would not expect you to just be walking around feeling awesome with like frank, hypokalemia. Yeah, exactly. Or hyper or whatever. Same thing. But I will say your creatinine was 1.23. And so creatinine, again, is this measure of how well the kidneys are, doing their job. The muscles every day will break down a little bit, release some creatinine into the bloodstream. That'll enter the kidney. The kidney does a good job at filtering that. And so if the kidneys are pickled, and that is not, a delicacy in anywhere in the world that I'm aware of. But if the kidneys are pickled, your creatinine level will tend to rise because instead of it being like excreted into the urine and filtered into the urine, it just builds up in the blood. And so, in med school or whatever, if you saw a creatinine higher than 1, you'd be like, ooh, is that something or is that nothing? And so you were 1.23. And now, granted, you're jacked AF, so we just assume that's due to increased muscle mass. Mine was a little lower than that, which is I'm not too pumped about that. I think it was 1.17, so I have some work to do on my muscle mass, or my kidneys are just great, one of the two. Yeah. But the interesting thing here, at least as far as I'm concerned with creatinine, is that people will, if they've been following Barbell Medicine for a while, will be like, oh, well, my creatinine was a little elevated. It was maybe the same level as yours, 1.23, right? Or 1.3. And they'd be like, well, it's probably because I just have all this muscle mass. Or I'm taking creatine, for example. And we know that creatine, when supplemented, particularly in the acute setting, so short term when people are just starting it, it does cyclize. So it changes into creatinine, particularly bad forms of creatine, like ones that don't get absorbed very well. So creatine ethyl ester, for example, crealkaline, for example, tends to raise creatinine levels higher, like real high. Like you could get a creatinine level of 8. And then if your clinician saw that level, they'd be like, you need to be on dialysis like now, WTF. So I see two errors being made around this when people see a creatinine level that's high. Error number one is just like ignoring it because people think, oh, well, I got a bunch of muscle mass and I'm taking creatine. And it's like, yeah, well, we should probably like just make sure. And you could do that with the cystatin C, for example, or a urine test to look at like creatinine in the urine just to make sure that that's normal. And then the second error that people make is that instead of assuming that an elevated creatinine level is normal, they freak out.
Yeah,
and they're like, well, my kidneys are pickled. I gotta, I need to get on dialysis right now. I gotta call a nephrologist. It's like, well, let's make sure that you're worked up adequately first.
Yeah, I agree. In general, my basic chemistry showed, for the most part, normal values. The ones that were not normal was the BUN that was elevated at 30. And that's something that a lot of people in this scene will get a common elevation in their BUN, and their doctor will just tell them you were dehydrated. I get that all the time. And most of the time, these are people who are not necessarily dehydrated, but a BUN can also be elevated from consuming a high-protein diet. So that's a very typical common manifestation of a high protein diet, is an elevation in the BUN measure. And yeah, my creatinine was 1.23. Actually, the highest that I've had in the past was around 1.4. I weighed about 20 pounds more then than I do now when I was in like peak powerlifting condition and shape. And so at that time, I had asked the internist who ordered that lab, I was expecting that result. So I said, can you also just order a cystatin C together with it so that I don't have to like deal with you worrying on the back end of this? And the cystatin C at the time came back at 0.7. And they're kind of analyzed along a similar scale or interpreted on a similar scale. So based on the cystatin C, that kind of was the tiebreaker and illustrated that my kidney function at the time was normal. And so that's essentially still the case. For whatever reason, it's a bit lower now. And between 1.23, 1.17 for years, also within an error bar of the test. So essentially about the same.
Yeah, so just for listeners at home, cystatin C is not affected by muscle mass levels or creatine supplementation. It's basically a more advanced diagnostic test to see how well your kidneys are doing their job. And so that's why we can use it to corroborate, or in our case, sort of make sure that our kidneys actually are working up to snuff.
Yeah, and the key or the caveat here is that even you could describe it as a bit more advanced, mainly because it's a little bit more recent, but it is not something that is ready to entirely replace creatinine because cystatin C has limitations of its own. So things like smoking, obesity, inflammation, steroid medicines, things like that can also impact it. And so we actually tend to get the best estimations of people's kidney function by using a combination of both measures of both creatinine and cystatin C. There's equations where you can plug both numbers in, and it tends to give you a better result overall than one or the other.
Yeah, and people might be thinking, well, look, if you're like going to reflexively check somebody's cystatin C based on an abnormal creatinine, like why don't you just add that onto the lab? Well, it's $120.
And most people aren't too jacked.
Yeah, or taking creatine. And then further, like this metabolic panel is actually a really inexpensive test. So you'd effectively, triple or quadruple the price by just adding this one mostly unnecessary test for the vast majority of folks. But if you have more questions on like kidney function and how exercise affects that, and maybe how your labs may be affected due to exercise, we have an article, Abnormal Labs and Exercise Part 1, Kidney Function, that's linked in the description below. All right, well, let's move on to the liver function tests that are also part of this complete metabolic panel. What's your interpretation of your liver function tests?
Yeah, so there are certain people, I don't know how many hepatology listeners we have who would be triggered by the phrase liver function tests.
Liver-associated enzymes, how about that?
Yeah, the modern term ought to be liver-associated enzymes. And so these include things like AST, ALT, and potentially a few others that are involved in this test. So mine were completely normal, and also not just completely normal by the lab reference range, but also by what I would actually consider to be a more optimal reference range. So this is one area where my view on what the lower limit of normal should be, it tends to and be a bit lower than a lot of labs call it, specifically around the ALT measurement. So these two enzymes are located within your hepatocytes or your liver cells. And when you have some kind of liver problem going on, leading to destruction or injury of these cells, these levels tend to increase as they get released into your blood. And so when these levels go up, they go up to varying degrees depending on what's going on. Somebody might have a mild elevation from fatty liver disease. Somebody might have a more significant elevation from hepatitis. Somebody might have an absolutely raging severe elevation if they go into liver failure, which is something that I see not infrequently from drugs like Tylenol, from contaminated workout supplements, from and a lot of other complicated causes. So in my situation, my AST was 24, my ALT was 17. And then the last caveat to add around liver tests, kind of like we had our caveats around creatinine, is that these enzymes are not just located in the liver. They're also found in the muscle of the body and various other areas. And so when people are very active, when they're training, if they have a muscle injury, a crush injury, if they have rhabdo, if they have an inflammatory muscle disease, all sorts of muscular disorders can lead these enzymes to go up. And also it is expected if somebody does like a hard training session that they'll go up for a little bit, but they should come back down to normal in relatively short order. That my ALT was 17 is the most reassuring thing. That is nice and low and indicative of like no significant, injury, inflammation, or anything like that going on in the liver that we can oftentimes see in patients with subtle fatty liver disease before it develops into more significant fibrosis of their liver and cirrhosis and so on. So there's a lot of folks who, there's some labs where, for example, the ALT lower limit of normal might be in the mid to upper 30s or even in the 40s. And I think that that's too high. So in general, I look for the lower limit to be cut off quite a bit lower than that if I want to be very confident that this person doesn't have, fatty liver disease, what is now called like metabolic associated steatotic liver disease, to make names even more complex. But fatty liver is one of the most common things that we see in a general outpatient population where there's a high prevalence of obesity. And that can sometimes show up on this type of testing.
Yeah, well, I got you beat. Again, if you're keeping score at home, I just definitively won the liver-associated enzyme game because mine were like 4 times higher than yours. At least the AST and the ALT. My GGT was about the same as yours, and so we don't need to rehash all of this, but it is reassuring to me, at least, that my GGT was normal, despite my AST and ALT being elevated. I trained 4 hours prior to like getting my labs drawn, and we've known that AST and ALT increase with exercise since like the 1950s, because again, they're found in cardiac muscle, skeletal muscle, kidneys, and more, and they seem to peak about 4 days after people train and tend to fall towards day 7, but they can stay elevated for many more days. And some of the actual studies on this, people have crazy high liver-associated enzymes, like into the hundreds, multiple hundreds. And I think one of the patients had like an AST value of like 900 and something after a hard workout. And I remember we talked about this on a podcast. I was like, hey, what would you do if you saw a person with an AST of like in the 900s? How would you react? And you were like, I'd freak. I would get a new lab test because I would assume it's wrong because that's so high that, if this person doesn't actually have like liver failure,
Sure. Yeah. I mean, I've seen cases. I have actually a patient in the hospital as we speak who has an AST in around 1800 and an ALT of like 2900, and they're in like approaching borderline liver failure. I've seen patients with severe cases of rhabdo who had transaminases like AST and ALT into the 2, 3, 4,000 range. And so it can look really scary in those situations. So not surprising. There is a lot of variation. Some people, they tend to increase a bit more with their exercise, some a bit less. Mine was not within 4 hours of a training session. It was first thing in the morning, and I had probably trained the evening prior. So I'd had probably at least, 16-ish hours from my last training session, and there was like no detectable increase anymore.
Yeah. Yeah. Again, the thing about GGT is that particular enzyme tends to not be elevated with training. And so there's been some thought that if you have a person who's very active and who does not want to like stop training for a number of days prior to getting tests done, that you add on the GGT and you're like, just to make sure, or at least make you feel better. It's hard.
Yeah. There are other ways to differentiate muscle stuff from liver stuff. And yeah, that's, I think, beyond the scope of our podcast for today.
Fair enough. All right. Now, here's where things start to go a little sideways here for you. Yeah. So they have this section of the test that you got done called immune regulation.
Yeah.
So they did obviously, they measured your white blood cells and did differential. And I'm like, why are they doing this? Because again, it seems like they're just padding the numbers, right? They're like, well, look, we can do an additional, 7 or 8 tests within this one specific analyte. Yeah. And then they also tested you for an ANA and a rheumatic factor, which WTF.
Yeah, this is where I started to get a little triggered.
Yeah, like I imagine you're reading your own results and you're like, why do they test this for? This is terrible.
Right. Yeah. So out of the CBC, you can extract the white blood cell count and the differential. And this was labeled as immune regulation. And this is, I would say, not an accurate description of what a white blood cell count and a differential tells you. It's literally just counting the number of cells that are circulating in the peripheral blood. And that's not the only place where these cells have a role to play. It doesn't tell you anything about the function of these cells. You can have, pretty significant immune compromise and have a completely normal white blood cell count and a normal differential. You can have, mildly low white blood cell counts and mild neutropenia and have a completely normal immune status. So it's just not a great test to assess that. So not something that routinely needs to be screened. But when it came to the ANA is called an anti-nuclear antibody, and it's a test that can, in broad strokes, relate to certain types of autoimmune conditions. Most commonly, conditions like lupus, Sjogren's syndrome, scleroderma, things like that are some of our ANA positive diseases. But there's a very significant fraction of the population who are completely healthy and have no symptoms or problems who incidentally have positive ANA measures. And so this is a test that is probably rheumatologists, that they're one of their most important tests on one hand, and also they're the bane of their existence on the other, because of situations like this where it gets tested inappropriately and it might come back positive. And then people get referred to a rheumatologist because the person who ordered it wasn't sure what to do with the result of that test that they had ordered. And sure enough, in my case, my ANA actually was mildly positive. These tests are measured in terms of titers. And so it's like a 1 to 40, 1 to 80. And the higher the titer goes, the more likely it is to be a significant. So if you have a 1 to 1280 titer or something, that's very high and very, that'd be more concerning. but mine was 1 to 80 titer, which is effectively meaningless. There's nothing to be made of this. If I didn't know anything about ANA, then I'd freak out and I'd start Googling and worrying that I had an autoimmune disease or that I had lupus and things like that. So I did not like that this one was ordered for sure. I don't think it's a good idea to be screened in the general population. And the same goes with rheumatoid factor. My rheumatoid factor was negative. Even if it had been detectable, I wouldn't have known what to do with that result because I have no evidence of anything rheumatic in my body outside of just some aches and pains that are more likely attributable to training than to an autoimmune disease.
That's what I'm saying, though. So imagine you get this test and you have no clinical training, right?
Yeah.
And you're like, well, I have had some aches and pains.
There you go.
And then
Yeah.
you get on WebMD and you start plugging and chugging. It says, oh, well, you could have lupus. You could have, all these things. And you're like, oh, crap. And then you go to your primary care doctor and you're like, hey, I'm really concerned that I have lupus. And they're like, why? And you tell them this test. And they're like, then they explain this whole thing. And ideally, you understand, right? And they do the teach back and the effective communication, and you're feeling like comfortable. But deep down in your heart of hearts, you're like, hey, can you just keep working this up though? Because I just want to be sure.
Yeah.
And then, well, that's not only expensive, but also potentially like anxiety inducing and everything else. And you may find some more weird stuff that is ultimately like not actionable, not meaningful, and big nothing sandwich or nothing burger.
Agree. This one definitely should not have been done, but here we are.
Yeah. For what it's worth, the surgeon did not ask from me to get an ANA or a rheumatoid factor.
Very good.
Pre-op. Yeah. He says, well, you're not 40 yet. And if you were 40, I'd have an additional set of labs that I'd want you to get. I was like, really? Just right there on that little benchmark? He's like, well, right now you're young and healthy. But at 40, and I was like, oh my God.
Yeah.
All right. So perhaps some of the most useful, or at least potentially useful labs that you had drawn, or was really just a standard lipid panel plus some more advanced testing for cardiac sort of biomarkers. So why don't you take the listenership through not only your standard lipid panel, what they could expect to get from one of those, but also some of the more advanced testing that you had done.
Yeah. So a standard lipid panel is one of the most common tests that are done from a screening standpoint and totally valid to be doing. Most people would benefit from getting lipids tested. And this is actually even an area where one of my other hot takes is that this should be done earlier in life than are commonly recommended by the screening guidelines. And so a standard lipid panel includes a total cholesterol measurement, an HDL cholesterol measurement, as well as a triglyceride measurement. And then from that, oftentimes an LDL cholesterol is calculated in most situations. And from that, from some of those measurements, you can then do a bit of simple math, take the total cholesterol, subtract your HDL, and you can get what's called a non-HDL cholesterol measure. So this is all the data that you can extract from a basic lipid panel. I think that in most situations, the total cholesterol is not the most useful outside of just absolute extreme high values. And then of the remainder, I tend to look at the triglyceride measurement, because triglyceride elevations, especially if somebody has high fasting triglycerides, that can be suggestive of some insulin resistance and diabetes going on, or prediabetes in that kind of insulin resistance spectrum. The non-HDL cholesterol is one of the measures that gives us a good proxy of the kind of the burden of potentially harmful particles in your blood. And then an HDL cholesterol on its own, if that's very low, that's also something else that'll get my attention. Sometimes we can see that in situations of insulin resistance. Sometimes I've seen that in people who are on anabolic steroids and things like that. So those are probably some of the most common metrics that I'll look at off of a standard lipid panel. Moving beyond that, an apolipoprotein B, or an ApoB measurement, is an even more accurate and useful marker for that overall burden of potentially harmful particles in your blood. So it's kind of like your more crude measure might be your total cholesterol, might be the most crude, and then a little bit less crude is LDL cholesterol, a little bit less crude or more refined is a non-HDL cholesterol, and then the most refined is your ApoB measurement. And then finally, a lipoprotein little a, lowercase a, LPA measurement is another one. We've done a whole podcast on LPA testing, and it's something that is heavily genetically determined. There are some impacts on its blood levels throughout life and with certain dietary interventions, but not very significant impacts. And so per current guidelines in some countries, they recommend just a one-time in your life screening for this. That hasn't yet been fully taken up in the US. There are other situations in the US guidelines where it's recommended to be checked. And so I had it checked myself before. I wouldn't have had it checked for another reason, but they happened to as part of this. And it was essentially the same as what it was in the past. So overall, for my numbers this time around, the key take-home points I would say is that the triglycerides were at 88 milligrams per deciliter, which is a pretty good place to be. A lot of times, reference ranges for triglycerides on standard lipid panels is about 150 as the lower limit of normal. I think that is too high. I would move that lower limit of normal down lower to around 100, meaning I would prefer it to be below that whenever possible. The higher it goes above 100, certainly the higher it goes above 150, I get more and more concerned about things like insulin resistance and diabetes. My non-HDL cholesterol on this test was 136 milligrams per deciliter, and I'll come back to that in a moment. The apolipoprotein B, or ApoB measurement, was 90 milligrams per deciliter, which is essentially right at the cutoff of where, it's claimed to be optimal, is like 90 or below, and so it's kind of right there. And then the lipoprotein little a was 19. Like I said, the last time, this is in nanomoles per liter, not in milligrams per deciliter, and so that's also in the very low risk range. That's kind of the overall take on those couple of those lipid parameters.
Yeah, what's interesting about this, and so just looking at your numbers, I'm like, I wonder if Dr. Baraki's happy with this because, part of me is like, well, you can't really calculate risk just from these numbers alone, heart disease and risk of, complications or major adverse cardiac events. It's more than just your lipid panel and, lipid related sort of measurements. You'd want to know blood pressure. You'd want to know BMI. You'd want to know smoking history. You'd want to know all sorts of things. And in fact, the new calculators take into account even so much as like, where do you live? Because the social determinants of health change. But, if you were a layperson and you did you were enterprising, you're a Barbell Medicine listener and you're like, you know what? I'm going to go get my lipids tested. And not only am I going to get a standard lipid panel, I'm also going to get an apolipoprotein B because those idiots talk about apolipoprotein B. And dang it, they had a whole episode on LP little a. So they got all of it. They did the thing. They did the Barbell Medicine way. If you go on and search for like, what are the optimal levels or what, target levels for these things, that is not an easy question to answer. You end up on various guidelines and they hem and haw back and forth like, well, this could be a risk factor in this particular population if you're this age or whatever. So anyway, long story long at this point, I'm like, if I had to guess, Dr. Baraki would want his own total cholesterol probably to be a little bit lower. He'd want his own LDL to probably be a little bit lower because lower generally is better. He'd want his own apolipoprotein B to be a little bit lower because, again, lower is better. And you're probably satisfied with your triglycerides. And I'm like, that's how I interpreted it. But at the same time, if that's with clinical training and also knowledge of you, the individual. So like, what's a layperson supposed to do with their own lipid panel results if they don't have a clinician that's like helping them out here?
Yeah. There's definitely a lot of thought that goes into this. And even this one lipid panel, to your point, it's like there are some things that I'm quite content with. Other things that at first glance, I was like, I would prefer that to be a bit better, but there's a couple other caveats to that. So one important thing is to recognize, we've talked about this a bit before, that lab tests are not perfect. You get a report of a number. I wish maybe that one day we can get labs to report the result and then what the plus or minus error bar is around that. That includes measures, for example, of biological variation. Some things just go up and down in people with time, day to day, hour to hour, season to season, etc. And then there's also something called analytic variation, where there's variation in the test quality itself, right? So if you run the same sample on that test multiple times, you'll get slightly different results. And so when you pool this error together of biological variation and analytic variation, it makes it so that if you're just looking at two values, snapshots, say a week apart, a month apart, a year apart, there's probably a much bigger error bar around that than it seems when you just see one hard number that's reported. And so to give a few examples, my last lipid panel that I had done, I think maybe a year and a half to 2 years ago, had numbers that looked at first glance a bit better than this. In other words, most of the values were lower. So the total cholesterol at that time was 171. The LDL cholesterol was 99 instead of 117 this time. The triglycerides that time were 58 instead of 88 this time. The HDL this time is 57, and it was about the same at that time. And so you might look at these two labs and you might say, wow, they looked better before, they looked a bit worse this time. So what I would encourage you to do, if this is something that concerns you or if you're thinking along these lines, is to go to this tool that we can provide a link to from the BMJ, the British Medical Journal, titled Your Results May Vary. If you just Google BMJ, Your Results May Vary, this will be the first result that comes up. And this tool basically provides a way to analyze biologic and analytic variation in these tests. So you can go down and you can select the total cholesterol or the LDL or the HDL, and you can put in the two different values that you are comparing, and it will tell you, based on the variation we know there is inherent to this test and biological variation, are these two results different enough that we know that there's a significant change, or are they within each other's error bar? And so, believe it or not, if you look at triglyceride measurements, for example, and you compare a fasting triglyceride level of 58 versus 88, they are within each other's kind of error bars, meaning that they are not different enough to where we can confidently say that it's worse this time and it was better before. If you compare an LDL cholesterol of 99 versus 117, same thing, within each other's error bar, and you cannot confidently say that it's any worse. And so when I actually punched those numbers in on my own to see, I was like, is there any significant difference here? And I came away from that not feeling confident that things were actually any much worse. And instead, I just focused on the ApoB measurement anyway. I said, well, the fasting triglycerides are below the level where I would want them to be, meaning low, nice and low in that 50, 60, 70, 80 range. That's great. And my ApoB was 90. If I wanted to be an absolute longevity maximizer, maybe I would get that down as low as I can. I do probably have some degree of some genetic predisposition for these to tend towards the, a bit higher from family history. I think that's a bit different in you. I think you tend to genetically have very low levels of this, and that's just probably something that we each inherited. And mine are in this like generally healthy range with all the lifestyle factors. But I do think it's important to point out how much variation there can be in these and using these tools to not draw premature conclusions. But to your point, this takes a lot of knowledge, clinical training, and like work to figure this out, which might not be readily accessible to everyone.
Yeah, even when like patients, like you'll have like a patient portal, right? And their doctor correctly got them a standard lipid panel, right? And those results will pop up in the portal, and they're looking at it, and there's a normal range and low and above, and people will see the results and can induce some anxiety about that. So very difficult, even if you do have access to a physician, but maybe not at the exact time that you see the results like come in. So one thought I had here related to this, like your results may vary, and this actually leads us into the male health sort of panel that you had run, like testosterone, for example. There is a relatively large amount of not only biological variation, but also like clinical variation, such that if you had a total testosterone level of 700 on one day, and then on another day, it was 450, that is within the error bar of the test. Yeah. And so if somebody who was maybe an optimizer, right, was like tracking their testosterone level over the course of a year, and so Q1, quarter one, 700, they're like, I'm way up there, baby. And then the next 450, like, oh my God, what happened?
Yeah.
And it's like, it could have been 450 earlier. We don't, it's within the error bar. It's meaningless. And so when people are like, my thyroid stimulating hormone is now 0.1 lower or higher or whatever, I'm like, it doesn't mean anything. And that's not the same for all tests, but just conceptually something to keep in the back of your mind. So speaking about men's health, you knew you couldn't get out of this without getting your testosterone checked. So I'll let you deliver the news here about your testosterone.
Sure. I mean, this is the first time I've ever had any of these things measured. I think we've been asked about this before. I think people might have assumed that we were people who were tracking this and were very concerned about it. I've never had this measured in my life, and I've never had a reason to. And so, total testosterone ended up coming out at 799 nanograms. The free testosterone was right around 100, and both of these are in the normal range. I think that they also did a whole bunch of subsequent testing in the realm of men's health and testosterone that was not generally appropriate. And this is testing that has its utility for sure. So this is measuring things like sex hormone binding globulin, prolactin, FSH, LH, estradiol. Each of these has their uses, but I do not think that they have a great use upfront as screening for the widespread population for sure, or even in a targeted way. Like I still do, I can understand the person who maybe they're a strength and power athlete and they're like, I want to make sure that this is like on track because performance really matters, or there's a big prize on the line or whatever, and I'm willing to pay to get this test done and make sure that it gets interpreted correctly. It's like, there are plenty of people who are doing that. I still don't think that even for someone like that they should get all of this subsequent testing done. These things are things that are done if the initial testing is abnormal and we're trying to figure out this person has testosterone deficiency. Where is the problem? Why do they have this problem? It's not necessarily something that you need to do right up front.
Yeah, I could make a case for, I mean, obviously right now, total testosterone first thing in the morning, that's like the general sort of initial test for testosterone deficiency. I could make a case for, hey, maybe we'll tack on free testosterone with that as well, because, people may have symptoms relating to that. I'm fine with that.
Yeah.
And then you would have a reflexive sort of additional testing if those came back or one of them came back abnormal. But in, the way it works right now is that if you have an initial total testosterone that's below the normal range, right, then you'd go back in and get a second test to confirm, and they would add on some of these additional labs to try to suss out why, if true. But if that second result comes back normal, you're like, oh, well, shoot, well, we just did these extra tests for, just in case, but we didn't really need them anyway.
Yeah. On one hand, I can see people might react and say, well, why would you, go through and get two, separate lab draws when you can do it all at once? But on the other hand, I have done many consults over the years for people who had completely normal testosterone-based blood testing, and their prolactin came back like just slightly above normal range, and they started freaking out that they had a brain tumor secreting like a prolactinoma. Yeah. And we had to kind of address that in that way. And that was potentially avoidable if they'd like just stuck with their testosterone, if they even needed to get their testosterone checked. As I said, this is not something I'd ever had checked before. I wouldn't have gone out of my way to get it checked because all of the effects, functions, training, mental, all the other aspects were completely fine and functioning for me. So it's not something I necessarily needed to get checked, but this is what came out. The other amusing aspect of a male health testing in this is that they actually sent PSA testing.
Oh boy.
So prostate-specific antigen, as well as more advanced prostate-specific antigen testing to include a free PSA, and then the percentage, the breakdown of that. So unsurprisingly, as a individual on the younger end of the age spectrum, my PSA was 0.4, which is very low. PSA, I do think, is something that is worth spending a moment or two on, because the general approach to its use and even my own thoughts around PSA testing have kind of changed over the years. I think when we went through school and training, you would get very polarized opinions on this. And I kind of ended up coming out on it's probably a bad idea to be doing this in most people. The idea of most people dying with prostate cancer, not of it. And then if you do the screening and then you have to go and you do biopsies, and the biopsies have complications to include, infections and erectile dysfunction and various things like that as a common concern. And part of the reason why my thoughts on this have shifted a bit over the years, I think overwhelmingly has to do with the advent and the advancement and the utility of prostate MRI, getting better and better and better. And so now when people if they are of the appropriate age demographic to get this done, which I am definitively not that, and I should not have had this test done at all.
Wait till you get closer to 40 when you're no longer young and healthy.
There you go. Yeah. I should not have had this test done for sure. But if somebody is in an appropriate age demographic to start screening for prostate cancer, I have increasingly come around to the utility of this test. And that may even, in certain situations, extend to the use of a free PSA to help to, suss out intermediate type of results. Like if the PSA result comes back between 4 and 10 or so, then sometimes these frees can help to delineate risk a bit further. But prostate MRI has led to so much better characterization of what's going on in the prostate gland, and spared people who don't need biopsies from not getting them, and then selected for people who definitely need to get biopsies done. So that's a topic that I thought was worth revisiting. I should not have had this test done. I think some people, more now than a decade or 20 years ago, I think can stand to benefit from it, especially if they have access to prostatic MRI if the result comes back abnormal.
Yeah. Yep. So moving on, they did some metabolic testing, and damn it, why are they testing your leptin? Like what?
Not only that, but one step further, they tested my leptin level, and it came back at 0.6 nanograms per mil, which is apparently below range, meaning that it was flagged as red, like abnormal, like it's bad that it's low. Do you mind just explaining for folks what leads to leptin levels in the blood and why it is amusing that a low level would raise concern?
I mean, yeah. So leptin is a hormone that is released generally in proportion to stored energy, principally in the form of adipose tissue, body fat, right? So when people have excess body fat, their leptin levels are high. And when people have low levels of body fat, their leptin levels are generally low. Now, the way that this has played out historically, probably over the last 20 to 30 years, was that people thought leptin was this sort of it's supposed to be like an energy regulation type hormone, such that if you had excess body fat, that leptin was supposed to travel to the brain from the body fat and tell you to stop eating because you had this extra energy being stored as body fat. We know now that that's not the case. Leptin doesn't work like that. In fact, leptin's sort of biggest role is in when people have low levels of body fat, particularly if they're either starving, for example, or have an eating disorder, something like that's consistent with like anorexia nervosa, for example, who have very low leptin levels, and it makes people very hungry. That's generally how we think of how leptin works. It does nothing really at high levels, and so not really involved in the sort of pathophysiology of obesity outside of like straight up you were born with leptin deficiency, for example, which is treated with metroleptin. So the idea that they tested for this,
Yeah.
right, and that you have a low level,
Right. Right.
and like even amongst like again eating disorders, anorexia nervosa, you cannot screen people with leptin to like definitively diagnose them because this is a clinical diagnosis. So it shouldn't have been tested, and certainly shouldn't have been reported as low. Because what is the advice? Like, hey, you should
Gain some body fat.
gain some body fat.
This is essentially a blood test to tell me that I'm lean.
I guess. Yeah.
Kind of.
But like
kind of,
too
yeah.
too lean? Is that what they're saying?
Clearly,
And-
definitely not. Yeah.
Yeah. They did test your blood sugar, and you did this fasting, right? And so you were 92 milligrams per deciliter. And so I would like to flex a little bit again if you're keeping score at home. Mine was 85 milligrams per deciliter, which, that's basically the same. However, mine was not fasted. And I would just like to flex my metabolic flexibility, if you will, here, that even after eating a meal, my muscles and my liver and my pancreas are so adept at clearing sugar from my blood that I had a lower blood sugar level than Dr. Baraki. So
Yeah. And this level, if it was on its own, even though it's technically below, it's considered in the normal range or below a level that would be considered like kind of pre-diabetes in the 100 to 125 range, the 92 would still get my attention as like, I would have expected that to be a bit lower. And this is a test that is super variable. This is like insanely variable, to our point about biological variability. This can be impacted by how you slept, by the meals that you ate the night before, by stress, by all sorts of different things. And so I was fortunate to at least see that there were other ways that this kind of metabolic aspect was assessed in terms of insulin resistance and kind of diabetic type screening. And so, for example, a hemoglobin A1C measurement, which is kind of also crude in its own ways, but a little bit less variable than a fasting blood sugar, was 5.2%. So that's definitely in the normal range. They checked a fasting insulin level, which is another way that this can be done, although fasting insulin is also pretty variable and has some downsides, but that was at 5.6. And so if it's in that around that range of, 5-ish, then at that or below is a pretty good place to be if you were wanting to interpret this kind of rigidly. But again, there's a lot of variation around fasting insulin levels. So those are a few of the metrics that were used. There are a lot of other ways to assess insulin resistance, and I think that we'll probably end up doing a separate dedicated podcast on that topic because we're probably due for a refresher for folks.
Yep. Yeah, exactly. All right. Well, speaking of useless tests outside of just leptin, you got a nutrients panel.
Yeah.
To be clear, the iron panel, it probably a low yield for like a man in his
Yes.
30s without
Yes.
like signs or risks for like anemia, for example. But iron testing and that whole iron panel, very useful globally, just
Yes.
due to the anemia being so common, particularly amongst women and particularly in certain areas of the world. So that's maybe my least offensive test that you had done. But like a methylmalonic acid and homocysteine,
Mhm.
an omega-3 to 6 ratio, like I know that if you're a maximizer, if you're a biohacker, optimizer, you're like, oh, I could do something with these. I'm like, no, you can't, because
Well,
the advice is the same.
Yeah.
You see what I'm saying? Like if you had a frankly odd, MMA level or whatever, you'd be like, oh, do I have a vitamin deficiency or whatever?
Mhm.
But you should have been symptomatic if to work that up. I feel like so.
Yeah, MMA is something that's used as a test to evaluate for vitamin B12 deficiency most commonly, and I had no signs or symptoms or any other evidence to suggest it. again, this is a situation where if somebody who is a maximizer and wants to pay for their own labs and stuff like that goes through this, then it's kind of whatever to me, because this is not a test that's prone to a ton of error,
Yeah.
fortunately. Meaning that I don't think there's a lot of scenarios where people can get a raging false positive or false negative MMA that'll lead them way astray, but not terribly useful. I wouldn't have checked it on myself. And similar for homocysteine relating to these kind of like methylation pathways that people like to nerd out about. I think more than giving them more value than they deserve. Finally, when it comes to the omega testing and like fatty acid testing, linoleic acid, EPA, DHA, all that. This is something else where it's like people who are ultra maximizers and want to actively manipulate their diet based on these kind of test results. That's like the super fringe scenario where people can do this kind of thing. But for most people, it's like, yeah, if you can eat some, fatty fish a couple times a week, it'll probably get you most of the way there. And some mixed nuts and things like that, generally health promoting foods that we recommend anyway as part of a health promoting dietary pattern.
Yeah, that's kind of what I'm getting at, because the people who are interested in testing like the omega-3 to omega-6 ratio, linoleic acid, DHA testing, whatever, if you're interested, first, if you're aware of these things and then you're interested in testing them yourselves, I assume that your dietary pattern already is like very good.
I would hope it's perfect. Yeah.
Very, very, very outside of like the carnivore, cohort, outside of that, your dietary pattern is very, very good. And so like it is improbable to me, highly unlikely to me, that a person who's aware of this, has the means to test for this, and is interested in the result and changing something due to the result, that they're going to find an action item in there that they're like, oh, I'm not already doing this. Right. Like your diet would have to be not very good. And in which case I would suspect that you're not aware of these things and ultimately not trying to optimize it anyway. Does that make sense?
Totally.
Yeah. Okay. Some other stuff that you got tested. Why, you were definitely due for a full thyroid workup. Complete thyroid workup.
Yeah. I think next to a CBC, the TSH might be the next most overperformed test in the world. A lot of patients that I see have like dozens of TSHs checked over time. Very much overdone in general. Mine was normal at 1.5, which I didn't need to necessarily have checked. But if people have like vague, non-specific symptoms, it's not the craziest thing. If people are having energy issues, sleep issues, mood issues, things like that, it's very, straightforward test to check. So I'm not going to be too much of a stickler around that. I do think that a lot of the other thyroid-associated tests that they checked were pretty ridiculous to measure. For example, measuring thyroglobulin antibodies in me and TPO antibodies and things like that. When again, those are tests that are used in situations where there's suspicion for possible autoimmune thyroid disease like Hashimoto's, but is not something that needs to be just measured in all comers. So mine were of course negative, didn't need to be checked at all. And then some of these other tests that were done, things like lead and mercury, that fortunately were undetectable. I was not suspecting.
You don't have heavy metal toxicity? You're just unaware?
I wasn't suspecting that I had it, but those were undetectable. There was a silly panel done to assess my pancreas that included an amylase and a lipase measurement, which those are tests that do not actually assess how well your pancreas is functioning or how poorly your pancreas is functioning. Those are tests that can be used to diagnose pancreatitis and not a ton else. So those were kind of silly to check. And then some other things relating to cortisol, for example, also a very, misunderstood test, I will say. It has a lot of valid uses in certain situations and less so elsewhere. We did a whole episode on cortisol and its testing earlier this year. And then finally, a vitamin D level that, of course, was checked. And so that goes along with CBC and TSH as among the most commonly overdone tests. And mine level was at 34 nanograms per mil for whatever that's worth.
Ooh, vitamin D insufficiency, sir.
I'm content with it being over 30, whatever.
Yeah, fair enough. What's interesting is that, you got hundreds of, biomarkers here, right? And this would have cost anybody else a small fortune to get this done, right? With, again, no contact with the clinical professional, right? Yet some very high yield labs were not performed that would, in fact, have a likely benefit on the public, not only your personal health, but public health, certainly. Where's an HIV test? No STI testing at all, right? Anyway, I'm just frustrated that this exists, that people are going to pay for this. They're going to get all of these biomarkers, right? And then what? what's the next step now? I mean, you had an action plan, and it was like, I don't have it directly in front of me. What did it tell you to like start eating?
It was kind of nebulous, and then it gave me some like recommended foods and supplements to take and other foods to avoid. And of course, the foods to avoid is like, highly processed sugar, like all the things that would generally be recommended to avoid anyway. So
Yeah, it'd be funny if you had like a different, you deked them out. You gave them somebody else's blood, right? Completely different results, but the action plan was the same. The supplements recommendation were the same. You're like,
yeah, it could be.
Not highly individualized after all, is it?
Right, yeah.
Yeah. So the only thing that I had tested was HIV, and I was non-reactive. So maybe again, something, if you are a direct to consumer lab like provider, maybe consider STI testing, just given the burden and like, depending on the demographics that you're testing. So I had this question. So, you basically were, recruited to get all these labs done. I had a set of labs that I needed to get done. They were told to me. I just did them myself, basically. But if we got to pick some labs for people, what would we pick and why? And I know screening is one of your favorite topics, like a bugaboo almost. So if you were thinking about screening, like basic screening, what would you think?
Yeah, I think that the hardest one to answer here is the concept of screening for just literally everyone. And that's where I would probably recommend the fewest things is for everyone, because I think most of the kind of use cases that we are talking about for various elements of testing are more useful and perform better and are more cost effective when they're kind of targeted to certain populations in a particular way, right? So this is why we put so much emphasis on like, yes, everyone should get a blood pressure. And I think that everyone should get a blood lipid measurement. It's currently remains controversial in some circles for understandable reasons of whether everyone should get, a lipoprotein little a measured at some point in their life. There's active ongoing debate. I think that debate will be settled in the near future as we figure out whether it's a treatable condition or not with benefit. But those are a few relatively basic ones. But I think most of the general, blood testing that we could do on people probably ought to be a bit more targeted in nature. And so there are areas where I tend to agree with certain, screening guidelines on population-specific targeted, testing, be it related to HIV or sexually transmitted infections or hepatitis C screening, for example, or again, nowadays, prostate cancer screening after a conversation with the patient. And other areas where I tend to deviate from the guidelines a bit more in that I screen for iron deficiency in menstruating women way more aggressively than is currently recommended, because I think it's such a prevalent problem that is under-recognized and undertreated. So that's kind of, I know that doesn't necessarily entirely answer the question, but that's my general take is like, I would probably pick the fewest things for everyone to get. Yep. And we would have to, hash out on a more population targeted specific basis what would be most useful to obtain for people.
Yeah, as we've been discussing, kind of offering some additional medical services through Barbell Medicine where people, for example, could obtain like our recommendations for laboratory analysis and like our interpretation of them or whatever. I kind of had run through this like use case or like an example of like, well, how would I want it to operate? If I could, we describe all of these potential problems. You're like, all right, well, idiot, solve them then. So in my mind, what would happen is people would arrive at a secure website. They would plug and chug their information into it. So their, age, their demographic, their medical history, their concerns, activity status, some, where they live or social determinant of health status kind of stuff. And a sort of suggestion box would pop up, right? Like these are the labs that we think you would stand to benefit from with a high degree of confidence, which would generally, to your point earlier, be a small amount of labs, right? And then it'd be like, but if you were of the opinion that you wanted maybe more, right? Like just to be, here are the other things that we think could benefit you, right? So not with the same degree of confidence that they would benefit you, but still like this would be appropriate, basically, right? And our value proposition, our value add would be, okay, so not only are we going to do the lab, like we're going to get the labs for you, we'll interpret them for you, we'll communicate the potential errors in the test so you don't have to, analyze that on your own. We're also going to give you some potential action items depending on your results, and there'll be some potential reflexive sort of testing or additional testing recommendations based on your results, rather than just leave you to DIY it your own. So I've come up with a few maybe examples here. One would be like cardiovascular health or cardiovascular risk, right? And so, yeah, you'd have a standard lipid panel. You'd have an apolipoprotein B. You'd have an LP little a. We'd ideally find a way to assess your blood pressure, right? Which we could do, in a roundabout way through a smartphone or wearable or some sort of other device. We'd ask about smoking, BMI, waist circumference, activity recommendation, whatever, and have a relatively, quote, holistic sort of view of your cardiovascular risk, right? All evidence-based, all, nicely packaged together. And we could move through, okay, what about like a metabolic health type panel, right? And so, for example, we got told that your insulin level was too high and your blood sugar was 92. And so you're like, I need to learn more about, I need more information. And so you've come up with some ideas around, well, how would you maybe test for like insulin resistance and, quote, metabolic health? So what do you think that test would look like?
Yeah, I think that each of these tests has some utility, but when there are large error bars around a lot of these, then sometimes other ones can give unique kind of perspectives on things. So for example, a fasting blood sugar tells you something about the person's degree of what we'll call liver insulin resistance, particularly if that fasting blood sugar is quite high. So if it's like 115 or 135 or something, this person has liver insulin resistance. The other way is their blood sugar after a meal or after an oral glucose tolerance test. That tells you different information. So that's, impaired glucose tolerance or diabetes range elevations. That has more to do with things like muscle insulin resistance, each of which has different implications and risk for progression to diabetes. There are other kind of newer metrics around this. For example, there's something called a triglyceride glucose index, which uses these simple measures that are often already collected. Your fasting triglyceride and your fasting glucose, and it comes up with there's a calculation around that, and it's actually it performs quite well as a screener for this, better than some of these other things on their own, and it's something that you're already measuring. We've already mentioned things like a hemoglobin A1C or an oral glucose tolerance test. I wouldn't necessarily put the whole population through an oral glucose tolerance test for sure. A lot of this stuff is going to be more targeted to people who appear to be at risk. So, for example, those who might say exceed ethnic-specific waist circumference cutoffs that we've talked about before. But again, if we have some of these folks who are just like all-out maximizers and wanted to pay for this stuff on their own, I think if they're wanting to do it, they should probably get it done in a way that's more accurate and readily interpretable than just getting every single test under the sun, including ANAs that they didn't need and leptin levels that they didn't need, and then wondering, what do I do with this on the back end? And so there are other tools besides some of these ones that I mentioned. People might have heard of the HOMA-IR test. That one has some issues with it relating to, again, some of the variability in fasting insulin measurements. And then a more advanced one called the LPIR score that probably is not being widely taken up in practice just at this point, and has itself some issues around measuring lipoprotein particle counts and things like that. So that's kind of the spectrum of tests that are being used in practice for, among certainly the glucose based, the A1C, things like that, among your traditional folks in practice. And then once you get towards this other end of like health maximizers and biohackers and optimizers, they tend towards the other end of this spectrum. I think there are use cases for many of these things. I think interpretation is where things get more challenging. Getting someone with expertise in interpreting them versus getting them yourself, and sometimes being a little stuck or unclear on what do I do with this information.
Yeah, I mean, that would be effectively our value add. We're like, look, we self-selected these labs because we think they're high value, and if you got like appropriately like navigated to them based on our sort of algorithm, and then our interpretation wouldn't suck, because that's the problem. You got a leptin level, it says low, and you're like, well, what do I do with this?
I already know that I do nothing.
Yeah.
But somebody else might be wondering, and they might go post on the internet, what do I do with a low leptin, or what do I do with my 1 to 80 ANA titer? It's like, well, yeah, freak out.
Freak out, yeah. Two other potential panels that we would consider. One would be like a men's health. And again, this would be like, first, just screen like, hey, are you sure that you need this? It'd be like a checkbox, like, you sure you need this, bro? And maybe you could do symptoms also, right? Do you have symptoms that are consistent with testosterone deficiency, right? And then if like somebody passed all of those, finally, then we could take their money, actually do the test. Because that's the thing, right? You can get a total testosterone, free testosterone, FSH, LH, whatever, all you want, without any check for like, hey, is this appropriate or not? you know?
A lot of the times it's not, and I think that that's an area of haziness out there where people get taken advantage of, inappropriately diagnosed, and definitely inappropriately treated. I cited some pretty alarming statistics on this in our testosterone course. The fraction of people who get treated for testosterone deficiency who have never had a testosterone level checked, or who get started on testosterone therapy and then never actually get a level repeated after that. So there's a lot of inappropriate practice and use out there. There's a whole set of symptoms, some that are very suggestive of testosterone deficiency, some that are very nonspecific, and some that aren't really suggestive at all, that people go down this rabbit hole and they can get themselves into trouble. This is another area where I've done at least as many consults over the years, here for people who had concerns about their testosterone or wanting to go on testosterone therapy, as I have people who ended up going on it and then they were like, crap, this didn't
I don't
help.
think I need this.
And
Yeah,
maybe
yeah.
I feel worse. Now, how do I get off of it? And so there's this, there has to be some kind of middle ground of appropriate utilization of this stuff, because I think it is, on one hand, the use of it is actually safer than a lot of clinicians recognize. It's quite safe when it's used appropriately, and there can be benefit for people who are diagnosed appropriately. So there is on one hand, a fair amount of stigma around its diagnosis and use. But at the same time, people go way off the reservation with how they do this a lot of the times as well.
Yep. Yeah, agreed. We could come up with more depending on the population and how deep into the weeds we want to go. But ultimately, any lab testing and interpretation that we would offer would be very sophisticated and not be a shotgun approach, just because that would cause, in our estimation, way more harm than benefit for folks. Although, hey, if you're into that, there are companies out there that are willing to take your money. We're just not one of them. So,
yeah, I mean, this lab panel that was done on me, I agree, was for the most part a nightmare in terms of its breadth and scope and general lack of utility compared with what people would pay for it. Obviously, the only reason I went through it is because I was invited, and I went through this almost as an experiment to see what it was like to go through. There's the frequency with which I do consults with people on these types of matters is what prompted a lot of this. People reach out and they contact us, they send in emails, and I end up meeting with them to talk about a lot of these things that were done inappropriately or were done and they're stuck with a difficulty in interpretation and things like that. So I do think there's a need for this. The issue again comes back to, is the testing being used appropriately for the population of interest? And is it being done from a screening side, from a diagnostic side? Is this person on the more health minimizer side of things? Or are they on the health maximizer and they want to do as much as they can, accepting any of the potential downsides, which, it's almost like a traditional view on harm reduction, right? It's these people exist. They're going to be doing these things and they want this information. And so maybe helping them use it most responsibly, there's maybe a role for that too.
Yeah. Yeah. Well, that is a wrap on our Direct to Consumer Labs podcast. Special shout out to Dr. Austin Baraki for lending us his clinical expertise. All of the stuff that we discussed, whether it's an article that we wrote, podcast that we referenced, guidelines that we talked about, or other papers, they're all linked in the resources below, or show notes below. Again, we do have a few new products and services that we've offered, so check those out as well. Before you guys go anywhere, please leave us a 5-star rating and a review. It really helps drive traffic to our podcast so we can keep bringing you all the latest nuance in health and fitness. From everyone here at Barbell Medicine, I'm Dr. Jordan Feigenbaum. We'll catch you next week and every week right here on the Barbell Medicine podcast.